Thank you everyone for joining us. We'll get started and we'll be recording this meeting to make it available to you via our YouTube channel at the end. Again, a very exciting May 2025 BrainX Community Live session. We have a very exciting speaker over here and a really interesting topic, very hot topic that we're going to talk about through our meeting. But for those who are joining us for the first time, BrainX Community was a platform that we created around 6 years ago with over 6,000 member international community. Actually, today our speaker is all the way from Singapore joining us early in the morning. So thank you, Professor Ngiam, for joining us that early. We have a very active LinkedIn group with more than 3,000 members. We share a lot of scholarly activity, a lot of scientific information related to AI and healthcare. So if you're not part of it, please join us there. And of course, our repository, our website, where we have a whole host of content that I'll briefly showcase. And we do these monthly live sessions to learn from our experts, just like Professor Ngiam today, and from others who are leading the work related to research and applications of AI in healthcare. This is our homepage where you can see any of the latest information about our community. We have our Connect segment where we post information related to upcoming live sessions, just like this one. And then once it's done, it goes to our YouTube channel. So even if you miss it, you can always watch it over there. So please subscribe our BrainX Community YouTube channel for that. As I mentioned, our very active LinkedIn group where we have people from all over the world with different backgrounds, AI experts, clinicians, venture capitalists, people who are from the industry, sharing information, sharing opportunities to work on AI and healthcare. In our Learn segment on our web page, you can find the latest and some of the best publications that we curate. They are curated based on their type. So you can look at it based on specialty or book or coursework that you might be interested in. We provide the links to those directly from there, and then you can filter and select whichever ones you want to look at. And of course, everybody is looking for open source data sets, and you want to build your latest and greatest models or maybe validate some other models. So we provide the largest repository of links to open source data sets, also curated for you based on the topic or healthcare specialty of your choice. And these days, foundational model or LLM related data sets are available too. So whenever they are open source, we provide that through our data section on our website. Our podcast series, which feature people who have been working in AI and healthcare and their inspiring stories, their journeys. You want to learn from them, how they got started, what inspired them, what they're working on, and what they see in the future. So subscribe to our podcast series through your favorite podcast channel, and you'll get the latest and the greatest through that. And then meetings and conferences, of course, you want to go and present your work or want to learn from others. So we present the listing of AI and healthcare conferences. These are conferences and meetings which are specifically focused on AI and healthcare. So you can look them up and you can plan to go to the next one. A couple of books as references. If you're lost where to get started, these might be helpful guides. The one on Voices of Innovation was led by Ed Marks and Sakshika Dhingra, along with Frank Pepe and myself. This is out now for pre-order, so you can get it and you can listen to these innovative stories from across the world, multiple contributors in there. This is what we had published in earlier in the year, which is the 2024 year in review. And what we had in this was a summary of the publications from the prior year. And the reason why I'm showing this is because there was a great story that was there in this year in review. So we have been doing this year in review since 2019. So we have the data from that. What was really interesting was the model types that are being researched and making it to publication all of a sudden changed. All of a sudden, we have large language model as the leading model type, whereas previously it used to be deep learning models that used to be the leading model. And you see that shift because previously it was all image-based data, convolutional neural networks. All of a sudden, with ChatGPT coming in 2024 and models following that, based on our methodology, we found that these mature publications, which have significant amount of data, LLMs are the most researched model types in this. And talking about not just LLMs, but other foundation models like the FMMM or the multimodal models and the vision models, they are also being researched for application in healthcare. So that was really interesting. This figure in the same publication talks about how every single specialty is experimenting with them. So it's not just related to one particular specialty. If you look at education, if you look at administration, that is again set across different specialties. But every single specialty is experimenting with these large language models for application, which led me to have Professor Ngiam over here, who I recently had the pleasure of meeting at the Mayo Clinic Datathon. He did a fabulous presentation that I thought would be great for us to get inspired from and learn from. And Professor Ngiam is currently a senior consultant. He is the head of thyroid and endocrine surgery. He is the adjunct professor in Division of Biomedical Informatics at the National University of Singapore School of Medicine. And you can read about his amazing experience and talents through our website. But with that, I'm going to invite him to talk to us about LLM applications in clinical practice, share his experience and his team's experience. So thank you, Professor Niam, for doing this so early in the morning over there and enriching us. We're really excited to have you here.
All right. Thank you, Piyush. Can you hear me well?
Yes. Thank you.
Thank you for this opportunity to share some of the work we have done here in Singapore. Very excited to be able to talk about LLM in particular, but I think I would start first by thinking a bit about how we implement AI in practice. So I suppose from previous talks and interactions, right? Many of us would be familiar with the use of LLM in practice, but as any hospital practitioner would tell you, it's never that simple, isn't it? So it's difficult because there's a significant IT resources that are needed to implement it effectively into practice. So I thought that I share a little bit more about how we go about solving those IT and change management issues before we go. I'll talk a little bit more about how we use LLMs in practice as well in Singapore. So I think to start off with, the intent of using LLMs and any kind of AI for that matter must be made right. I firmly believe that AI is probably good at augmenting doctors, but not replacing doctors. And the simple reason is because, well, primarily at this point, I don't think any of the LLMs are, or AI for that matter, is ready to be functioning autonomously. And most of the time, we are using it as a way to augment our decision making or support some form of administrative use case. Now, in healthcare, there's an additional consideration. So the key consideration is the medical legal consideration. At least in Singapore and as with many places in the world, the legal definition of care for our patients is a doctor-patient relationship and not a doctor-machine relationship or a patient-machine relationship. So because of that, when we develop and build LLMs, we are building them for the purposes of supporting our doctors to better support our patients. So I think that has to be very clear that we are doing this for our clinicians. Yeah. So as I mentioned earlier, one of the challenges we've had was, how do we deploy and support AI tools at scale, right? I mean, it's well and good to have one or two or three AI projects that happen throughout the campus, but it's another matter to have, dozens or hundreds of AI tools, right? So to do that, you really need to have some form of platform or some form of method to be able to scale up on the deployment of AI tools in practice. So to do that, we've built at the National University Health System, we've built platforms to improve the way we scale up and deploy AI. So we built three platforms, and I'll introduce them to you. So they are the three layers here. You can see I shared that previously, but just to walk everyone through this three-layer architecture. So we started off a few years ago with, quite a few years ago in 2015, 2016 with a platform called Discovery AI. So Discovery AI was built primarily to aggregate data and de-identify the data so that we can share that data equitably. So this platform is still continuing to operate, and it is designed to support our clinicians and researchers to aggregate and train AI models in a secured and equitable environment. So the whole idea of this is to bring data together, and that works great for what Piyush shared earlier as what we term as a classical AI or deep learning type of AI, where you are using some form of supervised or unsupervised learning to train models for specific outcomes. So we've been able to aggregate all sorts of data, everything from tissue repository data all the way through to clinical data, where we can use that information for training various kinds of AI models that we have brought into production today. So a couple of years of doing that, we've published quite a number of papers out of aggregating data. And this has culminated in, of course, many research publications. But we kind of realized that we could not go beyond that point, right? It was really hard to take those models that we have trained and put them into practice. So to address that issue, we built another platform called Endeavor AI. So this red layer here. So Endeavor AI is designed to support us to deploy these AI models into clinical practice in live, in real time, I mean. So how does that work, right? So we have connected this platform that is separate from our EMR system, and we've mounted all of models in this space so that the models are able to run live inferencing, right? So live inferencing is very different from training a model, right? We are using the AI models to make predictions rather than we are training these models. So when we're doing live inferencing, what happens here is that multiple models are running today to allow us to trigger alerts back to the EMR system, where our users can then use these outputs for day-to-day clinical practice or administrative use cases. So this has been transformational for us. It went live in 2021, and it has allowed us to sort of realize the dream of being able to deploy AI models into clinical practice. And finally, we have this other layer here. Just to mention, these two layers are on-premise kind of cloud-based instance, whereas the top layer here is the commercial cloud layer, right? This commercial cloud layer allows us to now access commercial cloud capabilities such as LLMs as well as multiple other services. So, and this particular layer, we call the healthcare commercial cloud, we are able to then connect to the internet via a what we call a border control service to access or support our users on the internet. So these three layers are then connected to each other and allows us to therefore have seamless connectivity in terms of the data flow, whether it's from the EMR system or whether it's from research databases and whether it's data coming from the patients. Okay, so we are moving towards a newer solution architecture, but I won't go into detail here. This is a bit too technical. But the solution architecture allows us to firmly move our services to the commercial cloud in totality. So including platforms like Discovery AI, which was around operational since 2018, we have been able to onboard multiple AI models as well, not on board, to train multiple AI models as well as multiple groups. So this at its peak, we had over 170 user groups using Discovery AI for all sorts of analysis. We have also mapped the data to the OMOP common data model, right? So we were one of the earliest groups to be able to map our data to the OMOP common data model that allowed us to then collaborate with multiple users across the world. And this OMOP mapping has allowed us to therefore change the way we collaborate with each other as well as with international groups and participants. Last 2 years ago, we've added a supercomputer to it. I think you'll be familiar with the NVIDIA kind of chip. So this is the sort of Discovery AI system diagram. It's a little bit complicated, but I just want to bring out 3 points here, right? So first thing is that we have a standard way of de-identifying the data. So that gives us the ability to link data sets up within the Discovery AI platform. The second thing is that there's a central governance mechanism to support the equitable use of and access to data. So one of the key underpinnings of Discovery is that we cannot take raw data out. You can take processed data out, but you can't take raw data out, right? And this is a technical way in which we ensure that people cannot take other data sets out of the system, but they can remove or export post analysis or post model building kind of information out of Discovery through a central governance mechanism, right? And finally, each group has their own virtual machine. So this is a internal cloud, is a private cloud that we have. And these virtual machines enable us to transact not just data privacy as well as data security, but it enables us to share the different use cases with different groups that they can work together, right? This enables people to share data and enables them to build on the models that they have been training on Discovery AI. So so we have a supercomputer attached to Discovery AI today. It's called the Precision Supercomputer. It consists of the last generation's A100 DGX boxes, and there are 5 of them for one hospital, right? So this is really quite a useful tool that we have today. So the use of Discovery AI has enabled us to do many different things. So for example, it has enabled us to collaborate with multiple groups around the world, right? In terms of things like OMOP common data model. So this is one of the publications that came out in JAMA Cardiology just around during the pandemic period. So we were able to run this very large multi-center trial across the Pacific area, consisting of almost 980,000 patients. And this is because we were able to map our data to OMOP and make that mapped data compatible with federated analysis. So we undertook federated analysis across well over almost 15 sites, and we were then able to put all that data together and publish this particular paper, which was we came out in JAMA Cardiology at that point in time. So like I mentioned, we could build all these really nice models, but we wanted to be able to productionize these models. And to do so, we needed a platform. And this is when Endeavor AI came in. Just to draw your attention to some interesting architectural constructs of Endeavor AI. So first thing is that it's built on a messaging system called Kafka. So for those of you who use LinkedIn, you would know that Kafka is a messaging system that LinkedIn has created long ago and made that open source. And we are using this as a stream capable platform, right, to enable data to be streamed across multiple microservices. So it uses a microservices architecture to enable auto scaling and fault tolerance, as well as being flexible in terms of deployment, right? So this is connected to the Epic EMR system. We use the Epic EMR system here in Singapore, and we have gone live since 2022, right? So we started alerting back to Epic since 2022. Okay, so in terms of sort of data engines and speed, right? So we are really well beyond just using ETLs and EMR systems as they are, right? Because using the use of AI tools is not dependent on the human being there clicking a button, right? So you can totally set up cron jobs or even event-driven kind of analysis. And because that's possible, we are really in the age of streaming, right? We can stream data much faster than we can ever before in terms of data size and speed. And because of the ability to stream data, we enable AI to be deployed, at speed and as well as at scale, right? I think this is what we're trying to achieve here with Endeavor AI. So within Endeavor AI, we have this Kafka messaging system, and this Kafka messaging system is the basis for which we have we are deploying all of our microservices. So you can see that we take all of the data from the EMR system as well as other data sets, and we publish them internally as a Kafka topic, which can then be subscribed by multiple microservices, right? These Kafka topics and microservices enable us to scale up the number of models that we can deploy at one time, and also to allow serial processing of AI tools. So for example, one of the AI services can process a stream of data and republish that information, which can then be consumed by other services, right? So this kind of publish and subscribe systems enable this serial processing of multiple AI tools to run as a possibility within the Endeavor AI system. So I'm just going to perhaps now change tack and talk a little bit more about what kind of projects we have deployed, because this is after all about implementation. And you will see also the different ways in which we can use LLMs using this architecture. So one of the earliest models that we built was a diagnosis predictor. So we call it Augurum. So this particular model, what it does is that it predicts the diagnosis based on the free text that the doctor has written in the emergency department. So this, for example, when we started, we just picked the diagnosis of appendicitis. Today, it can diagnose 12 different conditions, just trained on a multi-label classifier that we have set up to train this model. And it simply just comes up with a probability of a diagnosis, and then it suggests it to the doctor, who will then do different things depending on the outcome. And of course, we can retrain this model going forwards using new data, but what we call incremental learning. Now, incremental learning is not, I think it's a bit overhyped, right? The whole idea of thinking about retraining models has really undergone a huge change in the past few years. We found that actually retraining the model doesn't change the underlying model weight that much, and it's got to do with the size of the underlying data set. So this particular model was trained with well over 260,000 patients, right? So it is unlikely that there are significant shifts in the population that would result in a change in the model weight. And we have validated this more than once in our data set across the population as well. So, but interestingly, we are able to use the ground truth, right, to then train other models for other use cases, which I'll share in a minute. So the underlying model is really simple, right? This is a very classical convolutional neural network and recurrent neural network architecture using the LSTM model. So a really, really simple model, but because you are trained on highly annotated data, its performance is really still superior to large language models. So we've tested this with LLMs as well, and we found that actually this model works much better than the current generation LLMs. And using attention mechanisms, we are able to provide weights to the words or the tokens that are deemed to be more important in making a diagnosis. So you can see here for appendicitis, you can see how it highlights the important keywords like RF, pain, and so on and so forth. So you can see that the prediction score is here, and this is how it looks like to the clinician. And here, the clinician can then make a decision based on these scores to see whether or not they are correct in terms of their medical sort of diagnosis. And this is really acts as a physician aid, especially for the junior doctors, right? So we ran a randomized trial to show that this model indeed supports our clinicians to make better decisions, especially the junior doctors, right? It didn't help the senior doctors that much, but it did help the junior doctors make better decisions. So the same model is now being deployed to calculate a regression kind of outcome, specifically the estimated length of stay predictor. So what it does here is that we train the same set of data, but against the patient's length of stay, right? So what this model does is that it gives estimation of the length of stay of each and every individual patient who's admitted to the hospital on the first day of admission. So this is not the average length of stay, right? So it doesn't just use like 10 variables to predict the average length of stay. It uses the text that the doctor imputes when they clerk the patient, and it calculates the estimated length of stay based on the first day of admission, right? So this is slightly unprecedented because this has multiple implications. So for example, we use this initially to as a bed state management tool. So what it does is that it helps us, the administrators, determine how many days are these patients likely to stay and what is the bed state, therefore, of the hospital going forwards in the next 1 to 2 weeks. So this is how the estimated length of stay predictor works for administrative use case. But along the way, our clinicians also found that some of these highlights that you can see here, these attention weights given to these tools, are useful in helping them think about how to better manage our patients. So for example, we have a accountable care kind of team where they would focus on the patients with the high estimated length of stay. For example, anyone whose length of stay is estimated beyond 14 days, they would then sort of swoop in and try to put in interventions to reduce their length of stay. So these are more clinical use cases. And of course, the highest clinical use case is that if there were occasions where this was used to help support clinical decision making by bringing out factors that were important to predict whether a patient is going to stay long or not. So I have a personal anecdote to this, where when I looked at one of these models, outputs for one of my patients that I operated on, I was going to send the patient home that day, but the model predicted that the patient will stay 6 days. So this is day one after his surgery in the emergency case. But the model predicted 6 days, right? And I was quite surprised that the model predicted 6 days. So I told my team to just maybe keep the patient for another day instead of sending the patient home. And lo and behold, the patient suffered a stroke that same morning. And the team was able to jump on him and do some thrombolysis to prevent the stroke from progressing. And this I felt was surprising because subsequently the patient was discharged on day 6 of admission. So this was a very interesting anecdote, right? But that's it. That's just one case, right? There are a number of cases where tools like this have helped us make better clinical decisions. Yeah. Okay, so it's not just used for text-based analysis. We also use it as part of our pharmacogenomics program. So you can see here that we have currently a ongoing pharmacogenomics program that we've been running for the last 4 years. What it does is that we have preemptively sequenced now, right, about 5,000 odd patients in the community, and this sequence data is variant called, and then we are able to save that data into both a production database as well as a research database, right? So what the production database does is that if the patient now turns up to the hospital and the doctor orders a drug, it will check against that production database, and if there's a drug gene interaction, today we have 25 drug gene pairs that are validated for in Singapore, then a pop-up alert goes to the doctor to say that, oh, please don't order this drug, or order another, or change the dose of this drug so that the patient do not suffer a drug gene interaction. Now, this is in production for the last 2 years, and we have been seeing really good outcomes from using a tool like this. Whereas the endeavor here is really used to pull up the other genes that are relevant. So every time we sequence, we use a panel-based sequencing, we get about 500,000 kind of variants, right? So, you know, of which we only use 25. So the rest of the 400 odd thousand, variants are just kept somewhere, right? So we keep it here where Endeavor would then trigger a research database, a search, and if we find a variant of significance, then what we'll do is it will send an alert, a pop-up again to the doctor to say that, oh, uh, consider doing this, consider doing some gene tests for this patient, right, to confirm that the patient indeed has a gene of significance. So this is how it looks like. So this is like a pop-up. You say that, okay, you have a pharmacogenomics alert for phenytoin. There might be the patient has a HLA-B star 15 allele that is linked to hypersensitivity reactions. Please run a genetic test, right? Together the CYP2C9 genetic test as part of your pharmacogenomics panel, right? And then the doctor can go away and do that. So this is live. This is something that users can have access to on their EMR systems, and I'll show you how we do that in a minute. And this has been in production for the last 2 years or so. So we won an award for this. This is the first in Asia. I understand that in the stateside, a number of universities or hospitals do this. I understand that Vanderbilt as well as St. Jude's does this as well. And I have to credit them because this is something that we have learned from how to implement a pharmacogenomics program that is now live in Singapore. So earlier I mentioned about how does this appear to a doctor. So we have a common landing page. So it's an Endeavor AI web landing page. You can see this landing page here, where there are a number of, where we host all the different AI models that are within Endeavor AI. So the reason for this is because we understand that there are there's a possibility of alert fatigue for the doctors. So instead of having them being fatigued by multiple AI models triggering to them, we have a way to aggregate all the different alerts into a single page. So you can see the length of stay predictor here. We have another model called CHAMP, which I'll share in a minute. There's also a signaling back to this single landing page, right, amongst other AI models that are running. Okay, so I want to talk a little bit about change tag and talk a little bit about CHAMP, right? So this is a population scale chronic disease management program. So what does it do, right? It essentially, what it does is that it uses the data of the patient who comes to any of our hospitals or clinics, right, and calculates the risk based on the data coming out of Endeavor AI. So just to remind everyone that Endeavor gets all of the data from all of our hospitals and polyclinics. These are large clinics that are run by the government, right? And because we have all the data, we are able to then calculate a risk score. And based on the risk score, we can send a AI generated nudge to the patient, right? So the nudge is really, really simple. It's nothing fancy. It's not meant to be conversational, but it does nudge the patient to do certain things, like, for example, to submit their blood pressure results from their home BP sets, or to submit sugar readings, or so and so forth. And this then updates the weights and the calculation, which will then generate a subsequent nudge to the patient, right? So this has been live for the last 2.5 or 3 years. And we have now well over 12,000 patients on this program. And this loop here is completely autonomous, right? This has no human in the loop here. And we do look at the data and the statistics, but this bit here is completely autonomous. There's this section here that the CHAMP is used to provide clinical decision support and live dashboarding capabilities to our clinicians. So, for example, it's able to suggest to clinicians, right, the treatment guideline-based recommendations depending on the patient's outcome. So, for example, if the blood pressure is uncontrolled with a single antihypertensive agent, it will, based on the patient's risk factors, whether they have heart failure, whether they have kidney disease, to suggest dual antihypertensives to the doctor, so that we have consistency of care. So to be fair, I don't think it's something that clinicians would not know of. It's just to remind them to consider a dual antihypertensive and to support and to better have consistency of to have better consistency of care across the population. We also have this dashboard here that allows our care coordinator team to prioritize the patients who are either poorly controlled or do not respond, right? And of course, all the data that the patient enters is written back into Epic by the flow sheet, right? So for those of you who know how Epic works, so we are able to enter or write back the data into the Epic flow sheets. So this is like a screenshot of how the logic works and the specific wordings that we use. So first thing is that although the kind of responses are rule-based at this point, but we are able to personalize the blood pressure readings to our clinicians, to our patients based on a bell curve. So the first 30 readings or so that the patient enters, right, is we will plot a bell curve of the patient, right, to give us an idea of how well controlled or what's their variation in terms of their blood pressure across the board. And then depending on the number of standard deviations away from their curve, so every patient has a different curve, they will have triggered different kinds of readings. And I just want to show this because these words here are not written by the LLM. These are written by clinicians, right? And this is based on the consensus basis where we agree that these are the words. These are exactly the advice that we would give if a patient has a certain blood pressure variation from their bell curve mean. The scoring system is also customized. So we use a scoring, what you call a cardiometabolic scoring system to come up with what you call a segment score, right? So this is a risk segmentation score. We add it to the response score, that is how well they respond, how quickly they respond to a nudge. Now, if they respond quickly, they score low. If they respond slowly, they score high. Similarly, if their score is, if they have high risk factors or high risk scores, then they score high. And that will generate what we call a nudging score, right? A nudging score will allow us to then determine the frequency at which it nudges the patient. So again, we are seeing a fairly good uptake. This was data from last year, 10,000 patients. Today, we are about 12,000, almost 13,000 patients online. We saw in a review of the data, we saw a 4 to 11 millimeter mercury reduction in the systolic blood pressure of our patient cohorts compared to patients who are not on the program. So overall, we are seeing early data coming out of CHAM in terms of its effectiveness as a digital health tool. And going forwards, we continue to grow this service and to make it available to even more patients in our population. Okay, now changing the focus back to the hospital, we have a number of other services. For example, we use the data from Endeavor AI to put out live dashboards that we can see here, right, from the emergency department, where we can see different kinds of services being demonstrated here in a dashboard format. I want to draw your attention to the bottom left, which is a way to demonstrate or dashboard clinical information. So these are top principal diagnosis, fever, fluid overload, falls. So these are useful administrative tools, but we don't just want to use it for administration, right? We want to use it to help us better manage our patients. So for example, we have this 7-day predictor kind of window. So we can have, this is built on a standard AI tool that we are fine-tuned or we train on our models to predict the ED attendances 7 days ahead. So 7-day prediction window across the different bed states as well. So this was useful because it helps us manage our rostering as well as our manpower kind of allocation in the emergency department. And it also allows us to identify patients who have been staying for a long time in the emergency department. An interesting story here was that when we first trained this model on the English calendar, the Gregorian calendar, the predictions were all over the place, right? Today, this model has a accuracy of about 97 or 98%, depending on the day. And that was because we changed the sort of calendar to the lunar calendar and added in school holidays, right? So this really helps the model make better predictions, and it speaks of the fact that emergency attendances are closely correlated with public holidays, many of which are religious in nature in Singapore. So, for example, we recently yesterday we had a holiday, and it was the Vesak Day, which is a Buddhist celebration, and that's according to a lunar calendar, together with Hari Raya, which is a Muslim calendar event holiday. So holidays and school holidays have a high predictive factor for ED attendances in Singapore. Okay, because we have the data across the board, we are able to use all of the data all of the time, right? So, and we have this initiative called Horus. What's this initiative, right? Well, it's an initiative to use data across the cluster, means across all the hospitals and polyclinics, to pick up specific patients with specific risks and intervene in them, right? And Horus, as some of you may know, is the Egyptian god of healing, as well as the all-seeing eye, right? So it is exactly what it's describing. So what it's doing here is that it's able to see across the entire clusters, hospitals, and look for specific patients with conditions. So in this particular dashboard, we are using a particular project called CalSense. So I'm a thyroid and endocrine surgeon, and I'm interested in patients with high calcium, right? Why? Because some of them have a condition called primary hyperparathyroidism, which manifests as high calcium. Okay, so these patients with high calcium, it's super easy for us to just set a conditional range and just pick out all of these patients with high calcium, as well as if they had something called parathyroid hormone done. So if you have high calcium and high parathyroid hormone, you're almost certainly to have a hyperparathyroidism due to either a adenoma or a hyperplastic lesion, right? So today we have this in production where this dashboard is connected to our Teams. We use Microsoft Teams as a messaging system. And I get sent an alert every week to say that, okay, well, you have these 5 patients who have high calcium and have high PTH. Please act on it, right? So it's not just the endocrine surgeon, but our endocrinologists are also involved in this. So we have a workflow now to track these patients and follow up on them as these alerts pop out on a weekly basis, right? So this is super powerful. In the last year and a half that we've been using this, we have doubled our pickup rate of our primary hyperparathyroid patients. And why is this important? Well, typically it takes about 4 years, right, for us to from diagnosis to the point of surgery. It takes about 4 years, and this is not just Singapore numbers. This is international numbers, and the reason for that is because hypercalcemia is a very non-specific has very non-specific kind of presentation, right? And due to that non-specificity, is typically quite hard for clinicians to identify it as a cause of the problem, as well as to address it in terms of referring for appropriate treatment or surgery. So I think this initiative has greatly benefited our patients and reduced the time to intervention for our patients. You can imagine that if you can do that for calcium, we can do that for every other blood test. So you can see here, we have done that for, this is cardiocyte, we've done that for A1C, we've done that for different kinds of parameters that we want to use. So this particular table looks at A1C and EGFR status and whether the patient's on medications. I know the print is very fine here, but we have ranked them. So these are A1C values of like 11.3%, which is super high. And you can see some patients here, despite having high A1C, they are not treated with anything. So it could be administrative, but at the same time, it will be quite it will be a great lapse if we don't follow up on these patients who have high A1C and not being on any form of diabetic treatment. Yeah. So we have ones for renal as well. We have this renal dashboard that we use, and we can plot all of that data into a map. So Singapore is a small place. You can plot all of this information clinically into a map. This is primarily used for population health planning. right? But what's important here is this. We've done a number of different uh, sort of tests in terms of population scale use. So for example, we wanted to find out whether or not, you know, proximity to McDonald's was associated with obesity, and we found absolutely no correlation, right? In Singapore, as well as many places in the world, there's a lot of Mac delivery that's happening right now. But we did find a correlation between the um, the proximity to the food centers. We have these food centers called hawker centers, and obesity. So the closer you stay to a food center, the higher your odds of obesity and hypertension and other chronic diseases. Okay, just to change that again, I just want to go across the breadth of different models that we use. We also use AI for Holo medicine. So we use a tool called the Microsoft HoloLens 2 device. And this is used now for things like this, right? So this is projecting holograms onto patients during surgery. We've been able to train a model, a AI model, to show up the veins in the hands in real time. Just based on the near infrared light that we have coming out of the HoloLens, we realized that we could actually identify veins on the hands based on that reflectance, and we use the AI model to select uh, medium to large size veins that can be showed up on the arm like this. Yeah, and this is useful because it helps our some of our nurses to do some cannulation, as well as our interventional radiologists to do some form of vein mapping for a variety of different procedures, like vascular procedures. The same platform and AI models have been used to help us develop a nurse companion robot. So this nurse companion robot started because during the pandemic, this program started in 2020, and we wanted to support our our nurses especially, right, for these this repetitive work that required them to gown up and go into the isolation room and so on and so forth. There were other initiatives that used robots, but we realized that the robots were not very capable. So we decided to build our own robot. So to do these kind of tasks, right, to do fall prevention, to support portering of medications, to provide what kind of consumable refills, as well as to take vital signs from the patient. So this is our latest prototype. This is that is being built. It's called Missy. Just give it a name. Just an interesting fact. Missy is a colloquial name for nurses in Singapore. Just a fun fact over there. So it's a cloud robot where most of its 60 to 70% of its capabilities are based on the commercial cloud. And because of that, it is highly scalable, and we connected to the robot and the backend infrastructure via 5G network that we have internal to NUHS. And this is, as you can see, connected to the Endeavor AI platform, right? So Endeavor AI to the healthcare commercial cloud and connected to each of these robots by 5G. Okay, so this is one of a screenshot of our simulation world. So we run digital twin simulations. Today we have been able to build the digital twin up to level 4 digital twin, where we can control the robots through this the physical robots in our test zone through this digital twin, right? So this is all possible because of the platforms that we've built. Okay, so I'm supposed to talk about large language models in the last few minutes. So I think this was shared previously when I was at Mayo Clinic, but I thought it's important that I highlight a few use cases and how we deploy them. Again, none of these is possible without the platforms, right? If we don't have the healthcare commercial cloud, if we don't have Endeavor AI, we cannot use the large language models at scale. So we wanted to solve the issue of privacy, legal inaccuracy, and hallucination when it comes to large language models. And how we did this was that we built a specific, rather we fine-tuned and RAG'd a specific language model, and we call it RUSSELL GPT. Now, RUSSELL GPT is specifically tuned for healthcare, right? How does it work? Well, first thing is that everything is secure, right? All the model resides in Singapore, and we are secured behind a commercial cloud firewall, which is what I showed earlier, the healthcare commercial cloud. And this allows us to run the model in a secure manner whereby users can use identifiable information to on this model, right? Fully identifiable information can be used on this model without any limitation. And the whole idea behind this is that we want to be able to open up these capabilities to all users, not just a select group of users, and not have the limitations of being able to remove or needing to remove any of the identifiers that are present in, say, clinical text, for example, right? So this is how the architecture works. Essentially, Russell GPT is not a single LLM. It's made out of two different LLMs that we use a routing service. We can route the query to the appropriate LLM that is used for a specific purpose. So for example, we have a RAG kind of tool where we have different kinds of corpuses that are being curated by different clinicians. And that allows us to then route the appropriate query to the appropriate corpus and therefore return the appropriate reply based on a specific prompt. The same language models are used for a variety of different use cases here. So today, the largest use case is for secure English language tasks. Of course, it's not just English, right? We can use it for all sorts of things. We also found out that our nurses do use it for translation a lot because either they themselves are not native English speakers and or they want to use it for translation with our patients. Okay. So at the bottom left here is where we want to be. So we have already built and brought into production what I call AI tumor bots, where there's full automation and full automatic use of the LLMs. So for example, we have a model that we are currently using for breast cancer, which I'll share in a minute. But before I get there, I just want to ensure that none of this is just random, right? We have guidelines and guardrails, right, that we need to comply to in terms of the use of production level LLMs. All the usual clinical tracks have been fully deployed, summarization, referrals, letter writing, so on and so forth. That's been fully deployed today across the cluster. I just want to page forward to the large language models used for AI tumor bots going forward. So we also use it for education for different use cases. So this is for case vignettes. So if I may just push forwards to just show you how we use it for our AI tumor board. Now, this particular publication came out of the Lancet Regional Health, and that just essentially showed a 40% improvement in productivity for using LLMs in routine, clinical administrative tasks like summarization, letter writing, right? So, okay, so today we have, now this is again an old slide, but we have well over 4,500 users across the board. And, we are calculating some savings that we have seen across different use cases. And so this is the AI tumor bot that we have today in production. We call it Serenity Bot after one of the doctors who built it. Her name is Serene. What it does is that it takes the data from the EMR system and it automatically extracts the variables that are required and then puts it through the NCCN guidelines or the National Comprehensive Cancer Network guidelines and generates a treatment suggestion, right? So this is fully automated today. I just want to show this system overview. So it does two parts. So first part, it takes the data from Endeavor AI, pre-processes it. So this is normally done by a resident, and it will take them, many hours to do this, right? For approximately about 40 patients every week to extract that information and fill up that form. So this is fully automated today. And then the second step is to then use the LLMs to then that has a RAG built into it with the NCCN guidelines to then generate the treatment recommendation. So this is sort of like the form that has to be filled, right? So again, this is done automatically by the LLM, and this is the treatment recommendation. So very quickly to draw your attention to this, it doesn't just give a big chunk of paragraphs of recommendations. The reason for that is because when we first started doing this, we realized that it started becoming inaccurate as the recommendations went along. So what we did was we broken it down to 9 separate recommendations, which is what the NCCN guidelines would do. And And when you break it down into 9 separate recommendations, it can then predict, even not predict, it can then give appropriate treatment recommendations. Today, it's about 95% accurate. Where it goes wrong is usually in the genetic testing part, right? Where either due to a lack of patient information, like they don't know how many family members have breast cancer, or it gets it wrong because it doesn't have enough information to process the recommendation, right? So again, highly subjective, but in Singapore, at least this particular model is used as a quality tool rather than a treatment recommendation tool, right? Because the tumor board still assembles and still runs, so it kind of cuts away the time that is taken for us to run to assemble that data and to ensure that the recommendations are indeed aligned to the latest NCCN guidelines. Okay, so this is my last 2 slides, and I want to just bring the session to an end here by saying that I think it's a very exciting time, when we are starting to use LLMs in healthcare. There are significant risks associated with using LLMs in healthcare, like the ones I mentioned earlier. So privacy, legal inaccuracy, and hallucination. So we need to spend time to overcome these risks and to be able to deploy these models in a thoughtful and safe manner so that our users, our doctors have confidence in using this model, right? And many of the features that I shared earlier are designed for that purpose. So this particular screenshot, for example, is actually showing you how each of those recommendations link to a real world recommendation based on evidence. So again, these are important sort of features that we must build into a model to allow it to work. So yeah, with that, I bring my presentation to an end. I'm happy to take any questions.
Wow, this was just amazing. And again, like always listening to you, learn so much from all the work that you guys have done over there. So thank you for sharing this, and thank you for sharing the technical details and the building aspects, because people see just the end result of that and they think like, well, we need to build this, but what they don't realize is that it requires a lot of experience, expertise, yeah, to build something like this and to structure it the right way. So congratulations on the amazing work that you and your team have done over there. We have a couple of minutes. I actually have so many questions, but I'm going to try to cluster them into two groups. One is I see a lot of building in this is in-house, a lot of stuff that you have done. And these days, you see also a lot of vendors trying to sell you a lot of these products or these AI algorithms. Uh, what has your approach been in terms of like building a lot of these AI models within versus if there is a vendor-based tool or a product, then just integrating that into your AI strategy?
Thanks for that question, Piyush. That's a great question. So we often struggle with this, to be fair. There are many good products out there. We evaluate them and then we make a decision whether we would like to use them. So the evaluation for these vendor solutions are not just based on performance, right? Of course, there are other considerations, things like cost, deployability, features, and so on and so forth. So there are multiple other considerations, but broadly, I think that where we find that these models are commoditized items, we would want to buy them rather than build them. I think that's really obvious, right? So for example, at this point we don't want to say train our own LLM, right? So we use commercially available LLMs or open source LLMs and combine them in a way that we can use them. On the other hand, many of these models that we shared here are quite proprietary in nature, and very few or no vendors want to do them because they don't have the data to train them for that purpose. So those are pretty clear cut, especially if there are innovations that come out of the university or the hospital, then we're very clear that we would just adopt these ones that we have built.
That's great. I think the data architecture and how you have curated that is phenomenal. Using OMOP and having a clear data strategy. I think that probably is paying dividends for you. The other quick question I have is, I think you talked about this one use case, which was in the emergency department trying to generate diagnosis, and so it was refreshing to hear that because we've on our team also have experimented with this and found similar results. And what are your thoughts on that? So that particular use case was about generating diagnosis. And I think if I'm understanding it right, you had used some of the deep learning models, CNNs or LSTMs to do the diagnosis suggestion or generation out of that. And what if I heard you correctly? You said like you tried it against LLM to LLMs underperformed in that. We have seen some of those publications. Our own work reflects that too. Do you think that's like the limitation of the model itself, with the LLMs being most of them being just decoder models and not necessarily good at classification, or there whereas the LSTMs and others they do better at classification as a task compared to LLMs, which are more on the generative side. They do wonderful work in summarization and all, but for classification tasks, they may not be as powerful. What are your thoughts on that and using different models for different tasks based on their best performing abilities?
All right. Yeah, that's a great question. So, first thing is that these models that we have trained are trained as classifiers, right, for specific populations and data sets. So we were not surprised that they will outperform LLMs because LLMs are more general in nature and may not be able to fully understand the context in which the underlying text was written. So because of that, the LLMs don't perform as well. But you're actually right, right? If there are models that are more specific to a particular use case, like specific for a particular diagnostic task or what have you, then uh, of course we will use these more specific models. Then the question is, how can we put them together as almost like a mixture of experts kind of framework, right? Unfortunately, I don't have we don't at this point have the sort of bandwidth to kind of think about how we can put together large models, but rather we think of it as um, can we use it as a way to fine tune large models rather than to say that, oh, we would like to go and train a lot of these multiple models because it's just too much work to try to put them together in the future. Yeah.
Well, I think we're gonna have to bring you back because I wasn't satisfied enough. I would love to hear you more and take a deeper dive into some of these individual models. And this is just so much. This is exciting. This is amazing. And I'm sure our participants over here and then later on who watch it on YouTube channel will have questions and they can hopefully reach out to you to collaborate or to learn more from you. But first of all, thank you for waking up early. I apologize for having it early in Singapore and late over here in US. But thank you for this amazing presentation, and we'll come to a close this time. Thank you everybody for joining us, and we'll see you next time.
All
Take
right.
care.
Thank you, everyone. Thank you, Piyush.
Bye.
Bye.